So if you're not coming for the interpretation session, this is the wrong room. But I'm Esther Kim. I'll be helping facilitate the conversation today. So I want to introduce you to our team, our panelists here this morning. So why are we here and why are we speaking about this topic? So let me introduce you to Tae. Tae, can you tell us a little bit about what you do at Ethne and when did you get interested in kind of interpretation in the medical field?
Before I begin, I'm just going to give a little background about myself. My name is Ta, and I serve as a medical and actually legal interpreter in my community. I am originally from Maramo, refugee camp in Thailand. I was born and raised there. From a very young girl who started interpreting upon arriving to the state with no English background, I quickly learned how important clear communication, especially in moment of crisis, how important it is. And my background, because of that background, it's giving me the deep understanding of hardship and resilience, and and because of it, I'm very passionate about being able to give other, access the bridging that language gaps, both in not just legal aspect, but now in healthcare. And right now, at the moment, at Ethne Health, I serve as a registration coordinator, but also a Korean and Burmese interpreter.
Yeah, and I know, Todd, in your story, you was thrust upon this position because you had to interpret for your family a lot as a little girl, right?
Yeah. And I loved it. There was a lot of time where, like what I mentioned earlier, upon arriving to the state, you kind of just quickly had to learn it, picked it up. I'm not sure if you guys are familiar, but I remember my mom receiving a bill from, I'm not sure where, but she was like, "Can you figure this out? It has this bold red letter. What's going on?" And with those big letters, but over the time, those hard time, I was able to quickly learn what those mean, and now I'm able to utilize that and also help other, access,
That's awesome. We can't wait to learn more from you. Well, next we have Suraiya Sultani. Suraiya, tell us a little bit of your journey. How did you end up at Ethne, and what do you do there?
Hello, everyone. My name is Suraiya Sultani. I'm originally from Kabul, Afghanistan. I'm an immigrant. It's been only 3.5 years that I recently moved to United States. But when it was 2021, August, when Afghanistan fell down and Taliban took over Afghanistan, so we were trying to escape as well, other Afghans that they were trying to get inside the airport. So while we were getting evacuated from Kabul to Qatar, which was our first country that we got evacuated. So in that time, there was no interpreters who could help the Afghan speakers that they speak Dari or Pashto language. So I knew little of English, and I could speak my own native language, Pashto and Dari. So I jumped in front of everyone. I was like, okay, I'm able to interpret. I can help everyone in here. So at that time, I started working in the Red Cross area in Qatar, and then with the Homeland Security. And also, so my journey with the interpretation started since at the beginning from Qatar, and then after Qatar to Germany, and we stayed for half a month in Germany, and then from Germany to Philadelphia, from Philadelphia to New Mexico. And then in New Mexico, there was the place that I got to know a lot more how it works in in United States, how things goes around, how it looks the medical facilities, because I was working in the Red Cross area with a lot of people, and I was interpreting for medical. Even I didn't know some of the words in medical, but I was still try to find and Google and interpret for people. But it was a great experience for me. And then we ended up in Atlanta, Georgia, where because my uncle was living there, so we tried to get in Atlanta, Georgia. And then I had an appointment in Ethne Health Clinic with Dr. Esther that I was having a lot of, because I was so depressed because of those things when like through, it was going a lot when we were getting from Afghanistan to here. So we were like talking, and then I really found out ethne at that time, like it's so culturally sensitive, and they love how to take care of their patients. That was something new for me, because whenever I was like hearing like about America, and everyone was telling me, even in the camp, they were like, when you go there, you will find a lot of people, they would not like you, maybe, but it was totally opposite. I got loved, I got respect a lot in everywhere. And then couple of days later, I got approached by Dr. Esther that, would you like to work with us as a patient navigator in our clinic? And I was so happy, because when I saw ethne, how they care, how they love their patients, and I love to like help people. So I was like, yes, of course, why not? And ethne was my first job in the United States. And then I'm still like working in ethne health as a medical interpreter legally now. I got my certification last year, and now I'm working legally.
That's awesome. Wow. Yeah, we wanted to share a little bit about backgrounds. I think a lot of it just the history, and as you guys can hear, the story of resilience and the story of their heart of really wanting to serve their community is how they got into this. And so to start, a lot of you guys may wonder, like, why are we talking about this, right? So they've been done a few recent studies. There are not many studies that have shown that there's actually an increased number of limited English proficiency patients in the U.S. Predicted in the next few years, it might be 10% of our total U.S. population, over 25 million people, that is going to require interpretation. So whether or not you're ready, it's coming. And I know that at ethne, one of the things that we see is that last year alone, we saw a patient who spoke over 40 languages, and that was not planned. It was just the community was there, the community needed help, and we just started seeing patients that spoke languages I had no idea how to spell. And so this is something that is approaching. It's inevitable that you and I will see more and more of patients who don't speak English. And many of the studies have shown that if you're unable to communicate your needs, you're unable to get the care you need. Similarly, on the other side, if you're a provider, you don't understand your patient, you can't provide health care in a safe way as well as effective way. And so patient safety is at risk. And patients also don't know how to navigate the system because, as you know, our US healthcare system is not set up for people who are not English proficient. We have, go back to the other slide first. One of the studies I looked at, it showed that a lot of patients felt like providers don't use interpretation. And I know as a provider, I was not taught to do this in med school, and we were told, don't use Sericom, it costs money. You're like, okay, got it. But at the same time, I know in our times now, we are more relevant and more sensitive to our patients' need, and so please call the language line because providers really need to know what our patients are saying, and a lot of staff might not have training on how to care for patients that don't speak English. And many of patients that they have surveyed in one of the studies show that there was a lack of diversity in kind of the workforce, and so people fear even just entering into a clinic setting or a healthcare setting. Because a lot of it, as you know, is not just the verbal, right? There's the cultural nuances. There's a lot of things that you and I may not know, even just using Google Translate. It needs kind of this cultural interpretation. So as we talked about earlier, there's an increased number of patients coming your way that may not speak English. And why do we need medical interpreters? They do help us facilitate communications to provide accurate and effective care. Again, to have medical interpreters, they help improve the access to healthcare. Some of their stories, they haven't really shared, like a lot of their stories, a lot of them were fearful of going to the hospital and clinics, even when they were really sick. They don't want the bill. They don't think people will understand them there. And so people wait till the very last minute and use the ER for care. And you and I know that ER is not the place to go for primary care. And so having interpreters can really help us improve the access to healthcare, safety, their health outcomes. And to be true, like truth to be told, there are a lot of options now. There are a lot of creative options, and so we can't use the excuse that we don't know what to do anymore. There's phone interpreters, there's video interpreters. AI is there to help as well, and so I think it is time for us to really view this as a justice issue. Like, people really need medical interpretation so that they can get care, so that they can have access to the same access you and I have. But not everybody that speaks English in another language can be an interpreter. You probably know that. Just by a raise of hand, how many of you guys speak another language other than English? Wow, like 50% of the room. Do you guys feel like you can interpret if we ask you to? Some people are shaking their heads. And it's a skill, right? And so as you hear a little bit from Ta and Suraiya this morning, they have a passion for it, and they also have the nuance in their culture that they wanted to bring to the table and help. And so some of the skills that we have seen, and Suraiya talked about being certified. There's different certification programs available as well. You have to have strong linguistic background in your native language and in English. And so for our certification program, they have to take a linguistic test in English, because they may just be a good English speaker but not read or write, and that's really tricky to learn medical terminology, which is another skill you need, basic medical terminology. You're not going to med school, but you do need to know where the heart is, we'll talk about some of the words we'll use today. Cross-cultural communications, HIPAA, and really, at the end of the day, also trauma-informed care. A lot of our patients are coming from war-torn countries. To be an interpreter is going to be more than just words. You're going to have to show empathy and also trauma-informed care. All right, so that is the background of why we're talking about this topic today. The rest of the time, we're going to actually talk through some scenarios that we've actually faced at Ethne. There are going to be 4 different cases, and we'll have kind of topics about the cases at the end and discussions point, and then we'll also have some takeaway point. So let's move on to our first case. It's going to be me and Suraiya. All right, so this actually happened in our clinic. Hey, Suraiya, how's it going?
It's going great.
Oh.
Yeah.
It's going great? Yeah, hey, so remember Mr. Sultani? Mm-hmm. So we had sent him to get a biopsy, and we were probably thinking he had cancer, and it did come back cancer. It's kind of a busy clinic today. Can you just give him a call, just let him know we're referring him? And the result came back, and so go ahead and do that. Would you mind?
Yes, I can do that, but you know what? With Afghans, it's kind of different, because back in Afghanistan, there's like no treatments for these kinds of disease, like cancer or other things that they're a lot more worse than the other diseases. So I think it's better to just call them and bring them in the clinic and have a in-person conversation. That will be better.
You know that he already knew he was getting the biopsy anyway, right? Like, do you think this is necessary?
Yeah, it is, because I don't think that it's a good idea to break the news like this to them over the phone.
Yeah, okay.
Yeah, it's better to just schedule an appointment. I can do that.
Okay, yeah,
like
yeah.
Around 12 p.m. tomorrow.
Yeah, sure. Let's do that. Okay. All right, so Mr. Sultani is here. Yeah, can we talk to him real quick?
Before going to the room, Dr. Esther, can you give me a little quick brief?
Oh, yeah, I think that's a good idea. Yeah, so he is 58. She is 58. And she's coming in, and we did a biopsy of the thyroid nodule. And it felt hard on the exam, and so we knew it was probably cancer, and it's confirmed that it's cancer. I heard what you said yesterday, and I've been thinking a lot about, in your country, in many countries, cancer can seem like a death sentence. And so what would you recommend me do today?
So because it's a male, so don't do handshakes a lot, because they're a little bit culturally sensitive. But yeah, you can just calm them down, give them comfort, and let them know that we are in the United States, and we have treatment for these kind of disease. So
Okay, great. Let's do that.
Thank you.
Oh, sorry. Hi, Ms. Sultani. How's your family doing?
سلام خانم سلطانی. خوب هستین؟ چی حال دارین؟ چطور هستین؟
Yeah.
I'm good, thank you. How about you?
I'm doing well. Thanks for asking. So, do you remember we had sent you to get the biopsy of your thyroid?
یادتان است که ما شما رو روی کرده بودیم به خاطر بایوپسی انجام دادن گلوتان؟ Yes.
Yeah. We did get the result back today, and I'm going to tell you about it today.
خب پیش ما رزالت رسیده که امروز براتون معلوماتش میدیم درست؟
Okay. So unfortunately, we felt the hard lumps, and when they took a biopsy, it is something that we call cancer.
Just یک دقیقه خود صبر کنین.
And in our country, we actually have many treatment options for that type of cancer.
خب میگم ماینات شما آمده ده ماینات نشان داده که شما سرطان دارین کانسر هسته شما خفه نشین اینا میگن که اینجا امریکاست اینا در امریکا
Yeah. And I know that that's probably what is worrying you right now. We are going to be here for you every step of the way.
شما را هیچ چیز نمیشه شما جور میشین اینجا امریکاست تداوی هر چیز هسته. Okay, thank you.
Yeah.
Thank you so much.
Is there anyone in your family you want us to call to come here and talk to you about
در
this?
فامیل شما کسی هسته که میتونیم بخوایم زنگ بزنیمش؟ Yes.
Okay.
My brother.
Yeah, I know you want to involve your family, and so we can definitely have them come and we can talk together.
خب میگه خیلی برادرتون شما زنگ بزنین که باز بیای باز یک جای میشینیم که ما گپ میزنیم درسته؟
Okay. I want you to know that there are treatment options. I know in your country it may feel like there's nothing to be able to help, but we do have options for you.
خب میگن از اینکه شما تشویش نکنین در افغانستان که بودک میگه که یعنی تو کدام تداوی نداشتک ولی در اینجا امریکاست کل تداوی هر چیز شما تشویش نکنین.
Okay.
Okay, thank you so much.
Welcome. Did you guys understand all the Dari? She was saying exactly what I was saying. So a couple of things that we're going to learn from this case. Do you guys want to talk about? So I guess to the audience, what do you guys think?
Yeah.
What are some of the things that we can learn from the interactions? Just shout it out. Yeah, I think that's really important, right? So she said to understand what treatment options are like from the country of origin. And I won't have known that unless Suraiya was like, hey, let's brief about this. And bring hope because to her, and she understands this culture, and many of them have no treatment plan in their country. Yes, practice what you're going to say before, brief together. That's one of the things that Suraiya has really helped us at the clinic. She'll pause. She's like, all right, before we go into room 9, what are we going to talk about? What are the highlights? Here's how you say it, or vice versa.
Yeah.
Yeah, this is one thing I've learned from the hard way. Like, they really want us to greet their family or greet them. In America, if you're in med school or nursing school, like chief complaint, like what brings you here today is like the first thing you're supposed to say. But I've learned from our beautiful staff, like ask them about their family. And I got really nervous. I'm like, what if they want to tell me the 5,000 things their family's going through? And the reality is they won't. Or maybe they have. But just greet their family. They want to feel honor. They want to know that there is a relationship there rather than what brings you here today? What's your problem? I think just less direct and a more welcoming space. That's a really good point.
Because they come with a hope in the clinics that they think that these are all like family provider, family doctors. So it kind of like a family to them. That's why they always like respect and they want like to be asked about their health and their family member and they're like, yeah, kind of that.
And I'm not sure if you guys notice how Dr. Esther emphasized the treatment plan. A majority of the country, majority of the community we serve, as our titles say, refugee, immigrant. So a lot of them are displaced. They don't have the equipment or the care that we have here. So it's really important to emphasize that, and especially the word cancer, right? It's very universal. They know it, but they don't. Yeah,
they will just freak out when they hear cancer.
Yeah, it's really important that briefing, making sure they understand that they do have what we call hope here. Yeah.
Anything else from this case you guys wanted to bring up? I think the beauty of this is that you don't have to feel alone, right? I think a lot of times you feel like we have a patient who doesn't speak English, very complicated medical history. I have to spend only 15 minutes with them. There's a lot at stake. But at the same time, if you have a team and view your staff as part of that team, you're not alone in this. And working together as a team, letting your staff also take lead in some of the ideas, I think is really helpful. All right, let's move on to case number 2.
Hey, Suraiya, how are you today? I'm Dr. Bartolome. It's so good to meet you. Yeah, it's so good to meet you. So good to meet you, Suraiya. Yeah, just tell me. Hold on. Yeah, tell me. What brings you in today? Oh, you want a girl doctor? Sorry, we're actually all booked up.
Girl doctor, please.
Dr. Esther is already a little bit behind today. Yeah,
Girl
we'll just have to
doctor.
stick with me today. So tell me a little bit about what's going on.
I don't speak English. Go doctor.
Okay, yeah. Let me check. Okay, it looks like chief complaint today is you're having a hair issue. Do you mind just showing me?
Go doctor, please.
What do you guys think? What went well? What can we learn from the case? He was very friendly. He's very friendly. He was really friendly, that's all. Did you guys see her expression? Yeah. She was uncomfortable. And was she heard? She kept saying, girl doctor. Maybe. Well, I think he acknowledged it and said Dr. Esther is not available. So he did hear it, but he didn't respond to it or respond to it in a different way. Well, let's see the second part of the case.
Hi, good morning. Islam, Dr. Esther, how are you doing?
Good. How are you? Thank you.
How's your family doing?
Good.
How's everyone at home?
Good.
Good.
Doctor, I speak little English.
Okay, we
Yeah.
can get you an interpreter.
Thank you.
Yeah, so I can understand you a little
Thank
better.
you so much.
And, yeah. Okay, give me 1 second. Okay, I'll be right back.
Okay.
What are some of the teaching points from that? What do you guys think? Interpreter, respecting the needs of a girl doctor. Anything else? I know it sounds simple, but at the middle of a complicated, you're running behind, or you have a clinic that have no female provider that day, what do you do, right? A lot of times, we ran into that when we first started Ethne. I was the only adult female doctor, and so we had to reschedule, or they uncomfortably see a male doctor with a female chaperone. But at the same time, we want to provide care. And I think we're laughing about it now, but it happens, and it's so tricky. What if we don't have a female provider that day and no female chaperone? Like, what do we do? And so these are definitely things I'm sure you guys will run into as well.
Yeah, so as a Muslim interpreter, and you can see that I wear a headscarf. So some of the ladies that they wear headscarf and they're really strict with talking to a male person, they always go first with a female. They're like, we need a female doctor, or who is taking the vital, they need a female person to take their vitals as well. They always they look a little nervous and disturbed when there's a male person approach to them. But some of them are okay with doctors. They're like, okay, he's the doctor, I'm okay with the doctor. But some of them are not, especially who those are came from village areas. In Afghanistan, they never got any education. They're always being in the house, being a housewife only, not going out. So those people are yeah, they'll always ask for male, except for the female doctors. Yeah.
And it's tricky. We can control our environment in the primary care setting, but when we send them to a specialist, I can't guarantee they're seeing a female specialist. And so even just prompting them, hey, can we have a female volunteer going with you that can serve as a chaperone? But that takes time and effort in planning that. You guys want to talk a little bit about just eye contact, handshake? Because
yeah.
I know a lot of us make that mistake.
Yeah, as you could see, he just bring his hand to me and start grabbing my hand and shaking it. So it's kind of weird.
It's very Western.
Yeah. So kind of a lot of Asian countries, with the Muslim people and also Middle Eastern people, those people they wear hijab and big abayas, in really big long dresses. They'll be scared with a male person that they don't want to do any handshakes. Yeah. They're what is going on, why they're coming to me, and like why he's just trying to get so touchy to me. So yeah.
Yeah, Todd, tell us. I know in your community, we've made the mistake of making too much eye contact, or we feel like the patient's not paying attention because they don't ever look at me.
Yeah. Even I start doing it now. So, yes, eye contact can be very daring in our community. When you look at someone in their eye in our culture, it's like you're trying to compete them. You're trying to challenge them in a way. It's not about you listening, you're communicating. It's like, you're trying to test me, are you trying to, kind of thing. So for our elder, it's actually disrespectful. So we don't even actually look at our elder directly in their eyes. We kind of bow. A lot of Asian culture is similar, but we're a little different, but we're also like in the bowing. Respect for them as well. I would say eye contact is very, it can be very disrespectful in cultures as far as Burma and Thailand. Another thing is sitting. Sitting. We're directly, when, I think she already mentioned it actually, sitting.
Yeah. I think a lot of times for us to show that we're engaged, we pull up a chair closer to the person. And sometimes Suraiya will be like, you should go to the side of the room. Or some of them actually want to kiss you on the cheek. You're like,
Yes.
okay, like, I don't know what I'm supposed to do today.
Yeah, especially with Afghans, females, they're so friendly with everyone. Whenever we Afghans, we see each other, we greet like hugging and kissing on the cheeks. That's how we greet. And sometimes when Dr. Esther is in the room and she just handshake and then the patient just grabs her like kisses her cheeks. And I'm like, okay, it's okay, Dr. Esther. This is like how we greet in here. And I wanted to add about like the other one as well, that a lot of I would say Middle Eastern people, when they're like imams, they call it imam. I'm not a lot familiar with the Middle East people, but they're like not okay. They're female to start like talking while they are here in the room. They will be like, talk through me to my wife. So doctor have to talk to the male, to the husband, and then husband will ask questions from his wife, and then it start begin like that. And some of Pashtuns from Afghanistan, they're also like that. Some of them, I would say maybe 20% of them or 30%.
Yeah, and I have made that mistake before where I'm asking Suraiya to directly ask the wife the question because she's the patient, and the husband gets really mad and it's like, you need to address me first. Mm-hmm. I'm like, but you're not my patient. And I'm just learning, right? And she's like, okay, this is the way we're going to do it. And I think building that trust, and eventually some of the wives get to go to the clinic by themselves without their husband, mm-hmm. and then she's able to share what she needs without the husband.
Even that patient, same patient, next time first time when he met Dr. Esther, and then after that he was okay next time for Dr. Esther to directly speak with the wife. Yeah.
I had no idea. I was like, I'm just taking care of the patient. That's what I was here to do. And I think to point out that we will make mistakes. Sorry, guys. Like, for all those Enneagram 3s out there, you will make mistakes. And I think that's a part of humility, right? You learn, that is different, but it's beautiful. Once you know and you enter into these relationship with your patients and you care for them, you see the beauty of their culture as well. And last thing from this case, we didn't talk a little bit more on the case, was a lot of times our patients, when they hear you speak their language, they will start telling our interpreter all about like, I have this bill, I have this, I need you to pay my rent. Can you apply for Medicaid? And Suraiya just by like, she's a doctor. We'll talk about that later. And I think you want to talk a little bit about that?
Yeah, so a lot of patients, when they come in, when they feel like we're talking to the doctor, like they feel comfortable, they go through a lot of what they're gonna have, like what was having. Sometimes they comes with different questions, like, okay, I have this paper. Can you just interpret or translate it for me? I'm like, okay, we can do it outside of the room, but right now I don't wanna get the doctor's time so she can go and see another patient as well. So we have to stick with our time, that how much we have. So then the patients are okay. And then again, even I'm telling them, they're gonna again approach again back like, okay, what is gonna happen next then? If I don't pay this bill, what is gonna happen? I'm like, okay, wait. Outside of the room, we can help you out with our resource team. But inside the room, just talk about your problems. You're here to, you brought your problems to solve it through doctors. So just talk about that.
But many of them, this is the only person they know in the community that speaks their language and English. And they're like, I need all your time.
And
So.
adding on to that, I think a lot of it has to do with vulnerability, being able to be heard by someone, because again, we're talking about immigration, refugee, community. So they're migrating to this new place in the world, and they have no idea how to, they might not even know what resource team is, right? So. Helping them navigate, even though we are not supposed to, just trying to let them know, notifying them, clarifying it, I think.
Yeah, educating them about medical system in America.
Yeah, I think that's really important.
That is important.
Well, we'll move on to the next case. So you have a chance to come up with a word for our interpreters to interpret. And so we have a few examples of some of the hard words we found at Ethne, but does anybody have a word that they just feel like the interpreter never gets it right? Yeah, so the word is hiccup. How would you describe that in your...
Very funny. That was, you're right on it. It's like, I've told Dr. Esther, it's like watermelon. Yeah, people would interpret water, melon. Yeah, it's like that. So hiccup, it's, you gotta go about it, It's like
acting it out.
Acting it out almost. So, yeah.
But in Dari and Pashto, we have the word hiccup.
Oh, okay.
So it's easy.
That's good. Oh, sorry.
I just say hiccup.
Any other word that's been... Yeah, what's the difference between dizziness, lightheadedness, and anxiety? How do you...
So in Dari, we have those words. We have those words, and I explain the way it is, the same meaning.
Lightheaded?
Like headaches and
interesting.
dizziness and stressed or...
I speak two different languages, so I can, go a little further with this. In Karen is more of a minority, so there isn't a word for it. Burmese, there is a word for it. Karen, you have to go about it, explaining the detail of it. Migrating, so headache that's around your forehead, and anxiety, So you have to define it. You have to define it for them. So because we're minority, a lot of medical term does not exist. So sometimes we use visual to explain it to them, because a lot of them are again not educated. Does that answer?
Yeah.
I think the word anxiety is hard. I have a patient who came into our clinic, into the ER, constantly and said her heart is broken and her heart's hurting. And she's had so many EKGs, so many cardiac workup, and all she needed is because her heart is broken, that her family is in the war-torn country. And so how do you address that? But when she said the word heart, you trigger XYZ on your protocol. And so we've had to just navigate. You do need to do an EKG if you said the word heart, but don't just stop there. I think it's the heart behind that. What do you guys do? So we do PHQ-9 and GAT7. What I know we have it in Dari as well, but some of our patients don't read Dari. So what would you guys do?
So we just go I usually just go in through the same thing, and I explain what is it, how it looks like, and what we are doing. So
So actually, our clinic, they're very kind. Our clinic goes above and beyond. So when in those cases, when we have child, there was time where I have to sit down with the parent and explain each of the question, because it's very depth in it, right? So I had to take the time. It took about 30 minutes, but we got it done.
Yep.
We do need to,
Yeah, we take our time from if we are doing admin.
I think one
we
of
just
the feedback
take
they
it
have
out and
provided
give
for the
it to that
GAT7
patient
is
to
just there's so many
help them out.
options. How do you explain in the last 2 weeks? Sometimes a little. So then they kind of give time frame, in the last 2 weeks, was it every day? 3 out of the 7? You know, I think putting tangible and, because it's hard, you're like, likely, unlikely, a little likely. Yeah, and the comment is that just in-person interpreter can help with as extensive as the Vanderbilt forms to be able to sit down with the patients to do that. But that costs money, right? And so who's paying for that? But the outcome of it is really getting the kid diagnosed and to be able to have the right treatment plan. So we came up with a few words that we have trouble with at Ethne. So the first word is thyroid. A lot of our interpreters are like, where the doctor is like, you have Hashimoto thyroiditis, go.
Yes, I will go ahead, with this one. When you say thyroid, they think of oil coming through your throat, literally. So a lot of time there's confusion, and we have to explain that. And in Burmese, it's called si, lejang si. So it's like oiliness throat, basically. But a lot of time, if you're educated, you understand directly what that means. But if you're not, then they're like, what is that? What does that do to you? So you kind of have to explain it. And a lot of the time we use visualization, which is a picture right here that's provided.
Yeah, adding on that as well, like a lot of Afghans, they are like illiterate. Not a lot of them familiar with, even when I tell them, we have this word thyroid, which is, we call it thyroid. And sometimes they think, do I have a tire in my throat? I'm like, no. So we just show them the pictures. So it looks like this, and it's in your throat. It will be like a fat. So, yeah.
Next one is, I get this a lot, IUD. So we do a lot of family planning in the clinic, and I get this blank stare when we say IUD. Why is that?
Okay. So IUD in Dari, when doctors are like saying IUD, we have like multiple birth control for you, but when Dr. Esther, like, no, I mean, not only Dr. Esther, but all doctors, they won't say IUD, so they're like, what is that? What is IUD? So we have specific word for it, like loop. So it's like they know it. A lot of like Afghan females know it. Like I would say 80% of them, but they're not familiar with like a depot shot, with injection. I mean, with the Nexplanon, yeah. So they're not familiar with that. Sometimes when we say Nexplanon, they say it capsule. I'm not sure why, but it's so kind of confusing. Even the first time when I heard I was telling the patient, we're gonna give a Nexplanon to you. She's like, a capsule? I'm like, no, it's not a capsule. It's not a medication. It will be a tiny little rod, so you're gonna get that. We have to like a little go through it, like show the pictures, the diagrams on the computer, or we have like some pictures that we already have it in our clinic, so we can show it to them like how it works and how we're gonna do it for you. Yep.
Yeah, I think some of them, like, you would be surprised. They already had it in their arm, and they're already, IUD, it's already done, but they didn't even know, like, what's being placed in them. So being able to, explain that to them and interpret is very important. IUD, there's no word in our language, again. Especially in Korean, there is no word for it. You have to explain it, again. Next one on, there's no word. The pills, there is words, but the others, they don't have it. Like Suraiya had mentioned earlier, adding on to that, for some reason, a lot of them think Nexplanon is a pill. I'm not sure why, but even in our culture or our community, they think there is a pill being placed in their arm.
Yeah, they hear it from other ladies. We see a lot of Afghan women that they come with. Okay, let me tell you a story. There was a lady, she came in our clinic and she was like, one of my friends, she got a capsule in her arm. I want that. I'm like, okay, let me just talk to the doctor and we can have it. And inside the room, she starts saying, I just need that capsule. So the doctor wanted to like explain how it is and how it will work. And we were like telling her, this is gonna be the problems you're gonna face with it. So she's like, no, I just need that, just the capsule. And after 3 or 4 months later, she came. She's like, I'm not having my cycles. I'm having headaches. What is this all? Just take it out. I don't want that. And so, these things like we get in a clinic a lot with a lot of female patients that they're not educated. So, yeah.
And so I think just the 3 simple alphabet, IUD, means a lot to us, but it does not mean a lot to the communities. And it was the first time I heard it's called a loop. I'm
Loop.
like, why is it a loop? I don't know. Next word, what's on our list? Oh, yes, cancer prevention. Do you guys do cancer prevention screening in your former countries?
No.
Not yet.
Oh,
What is that?
but mammogram, yes. Some of the ladies, they know about it. If the doctor would tell them you need this to do it, but they're not gonna do it because there's no cancer screenings. Yeah.
What about you?
Same. If they're doing it, that means there's something the doctor or the provider has already detected, majority, so they don't have that either. But we provide that.
Yeah, I think that's been a learning curve for us because we talk about it like everybody's doing it, and they're like, no one is doing it. But then they feel scared that, what are you trying to look for? Do you think I have something wrong with me? But we kind of just have to make sure, like, hey, we do this for everyone that's over age 40, age 45 for colon cancer, and you, as well as my next patient, are being offered the same option. And so they don't feel like they're being singled out. But then we started getting questions about what does the procedure look like, right? You're like, I'm signing up for colonoscopy, you. And they're like, what does that mean? And we've had a few patients where they did not do the prep, and they show up and they said, did you drink the thing yesterday? And were you in the bathroom all day yesterday? What's that? And then they didn't do a prep, and they didn't get to do the procedure. And so one of the things that they're showing up there is actually our cancer prevention cards that we printed out at Ethne for our patients to see, the camera is entering into your bottom, and this is why we're doing it. And so just some of the visualization that we started using, because we were throwing words like mammogram and colonoscopy, and patients like, yeah, yes, doctor. They don't want to disappoint me. They want to honor me, and then they don't go because they don't know what it is, or they get really mad when they get there.
Yeah, sometimes when they did not have drink the water or the solution that they have to, they just send them back. They're like, go back and do it and come back with the results.
Yeah. Well, let's talk about the next word. It's called tissues. How do you even tell me about how do you define, or not define, interpret the word tissue?
I'll start. So tissue, they know tissue, the toilet tissue paper. But tissue has so many, right? Like we have organ tissue, we have skin tissue. We have to explain that. Skin tissue is the external factor of your skin. And it's just, again, picture a depth of it. We have to go about and explain it. It's not just one word. If you're, for example, if you're in, explaining, say, patient has a problem with tissue, but if you're using it over the phone, that person, if they say tissue, because there is no word for it, a lot of time, I've noticed too in my, throughout, working, I've noticed that because with the time and professionalism, we're a trained interpreter. If you're certified, I know, you're trained to say exactly what's mentioned. And a lot of time, because we don't have that word, they would just say tissue. And that can be a lot of miscommunication. And a lot of time, because patient does not speak the language, they're kind of just shied away, and they're like, yeah, okay. Yeah, and they just take it from there.
Yeah, for Afghans who are not educated, they never have been to schools, they would not know what is tissue. The way, Ta explained, we explain to them what is tissue, but some they are educated, we just say tissue, but some they are not, they're like, am I having tissue paper in my body? I'm like, no. Yeah, so.
All right, let's talk about this kidney stone. I know this was an incident that we had in the clinic. Tell us about how you would explain kidney stone to a patient.
So kidney stone, when we talk about kidney stone, they think a stone is being stuck in the stomach, not kidney, not gali. Gali is kidney in Korean. Chauka is kidney in Burmese. And when you say you have chauka in stone in your kidney, it's like, oh, is it like it's just stuck on it? But we have to use, I'm not sure if you guys are familiar with a boba. Boba, have you guys drinking? Yeah. So we will use example of boba being stuck in the straw to explain it. Yeah, that's one of our popular, that's why our popular demo. this is why we choose Kyrgyzstan as,
Yeah, I think this was a case where we were trying to explain to the patient, you need Flomax, and this is why, and you need this, and this is why it hurts. And they're like, what is happening? And then the interpreter was like, Dr. Kim, tell them about boba stuck in a straw. I'm like, oh, yes. And the patient's like, of course we need the boba out. And so then they were more willing to take the medicine.
Next.
All right, we're going to wrap up with our last case, and we're going to have Ta and Suraiya act out the last case.
Hi, good morning. How are you?
I'm
It's been a
good.
while.
Yes.
Yes, how's everybody doing?
Everyone is good. I'm sick, and that's why I showed up today.
Okay,
Yeah.
before we start with anything, I'm looking through your chart and I see a history of thyroid. Have you been taking your medication?
Yes. I took the whole bottle that you prescribed it to me for a month.
Perfect.
Yes.
For 1 month.
Yes.
Oh, 1 month.
Yes.
What about the refills? I
don't
sent out
know
3
about
refills.
anything. You give me only one prescription. I got one prescription. only.
Oh, so there's actually refills with that. Okay, we can talk about that. I'll send out more refills for that
Yeah,
too.
but today I'm here because I'm sick. My kids are sick. My whole family got flu, and I
Right.
need medication.
Yes. I actually saw you got swabbed. You got swabbed for strep, COVID, and they all actually came back negative. So you actually
but
don't need
you-
antibiotic.
But no, back in Afghanistan, whenever I was going to the doctor, they will just give me antibiotics, even the injections. You just give me the medication.
Well,
I'll be fine. I'll give to my kids and my husband as well.
Yeah, well, the thing is, that's all the tests, we tested you very thoroughly, and it all came back negative. So those are not needed. Yeah,
But I just need medicine.
yeah. And for your children,
Because you know that you mentioned in the first, why are
Yes.
you not coming? Because we were not sick.
Right,
That's
right.
why we were not showing up
Right.
in the other appointments. But now I'm sick. My baby is sick. My other baby is sick. I just need medicine.
well, so
Please give me medication. I just need medicine, please.
right.
Yeah, give me amoxicillin, okay? I don't want any other one. I tried to give my kids Tylenol. It's not helping. It's not even helping. It works for only 2 hours,
Well,
and
so
then
today's
he's gonna
visit is
get.
for you, okay?
Okay, but give me medication, amoxicillin, 2 bottles. I'll give it to my whole family. Yeah, just give me medication. Where are you going?
Sorry, no antibiotic.
Get out of there. How many of you guys have experienced that before? Really? We're not alone. So what do you guys think? What are some of the cultural beliefs or cultures at play? I would say it. So the comment was that a lot of them in pre-departure to the U.S., they're in refugee camps. And so there's this tent, and you can go and be seen, walk in with your 10 kids or however many, and you will receive something on your way out. And so if you are not giving something in your visit, they don't think you're a real doctor.
Yeah.
Yeah, so the comment was that in other countries, they may prescribe more, and when you don't prescribe, as you shouldn't, you should have antibiotic usage carefully, then you are viewed as a bad doctor.
Yeah.
You guys want to talk a little bit about this case?
Yes. So refugees back home, I remember, houses are built with bamboos. We have a very large camp, and that whole camp is a very beautiful camp. However, we only have one clinic. That clinic goes, or the hospital, not clinic actually. There's no clinic. There's a hospital. Hospital is being used when you're basically in a life and death situation. So it's kind of like, oh, you're having a malaria, so, oh no, I have to go to the hospital kind of thing. So automatically, if they don't feel good, they're giving immediate doses of, antibiotic just to make sure, it doesn't come back, because there's no preventative care. And over here, it's primary care is preventative care. So that doesn't exist. And following that, well care, different belief, right? Well care, preventative care, well care, annual well visits. They don't have that. So again, being able to culture them that it is, we are here to help, but in a long term is also very important. Yeah.
Yeah, within Afghans, I would say like all Afghans and Asian, like Indian and Pakistani, because I do interpret in Hindi and Urdu as well. So a lot of them, they just walk in, especially with our Indian community, they will come when they have, like, as she mentioned, like, it's situation for, like, death, and, I mean, like, they're going through a lot. So, yeah, they're like that. But Afghans, they will be, like, really quick. If they're gonna get fever, they're gonna walk into the clinic. If they're coughing, their baby's coughing, they're gonna walk in the clinic. They're like, I just need medication. If we can't see them, they're like, what kind of clinic is this? Or why are you not seeing us? Because back in Afghanistan, when you're like, even have a little fever, they even don't check their temperatures at home. But when they just put their hand in their forehead, they're like, oh, my baby is having fever, or I'm having fever. They just run to the clinics, and they get IV, amoxicillin, injections, all these together. Yeah. For 3 days, 4 days, back to back.
Wow, yeah.
Yeah.
And I think to understand that, a lot of times we have compassion for our patient, right? They're not just out to get us. They're not trying to be annoying. But a lot of them, they've also had to advocate for themselves at every checkpoint of their journey. They've had to be bold and ask because they've been said no for so many times. And so I think understanding there's cultural beliefs, they're really trying to advocate for their patient, their family. You kind of have compassion entering into that situation and not be like, you're just being mean to me today. Other things that I think is helpful to know is the idea of chronic and acute care. A lot of our patients really just take 1 month of metformin and they're like, my diabetes done. It's cure. And the idea of taking something long-term is very foreign. And we know that diabetes can get better in the short term, but a lot of times it does require a lot more medications.
In Afghanistan, there is like no family providers. Only the rich people have family doctors, not like the middle class or the poor people. When they walk in the clinic, they don't get their follow-up appointments. They're like, when they're sick, they just walk in, as you just saw that the patient was like even didn't show up for a year, and then she didn't take our medication. So they're like, when they take just only one bottle, they will be like, okay, we're done. I think I don't have the diabetes anymore or the cholesterol or whatever. So yeah, it's kind of so hard to explain to them about medical terms in here and back in Afghanistan how it was. So yeah.
Yeah. Well, we're going to spend the last 5 minutes. It's been a really exciting time, I hope. So you and I may have experience, and many of you guys may have experience working in clinics that have interpreters, but many of you guys may not. And you're thinking, what can I do? What are some of the takeaway points? And so we've kind of gathered a few things for you to take away, whether or not you have interpreters already, if you're not. But here are some of the tips that Ta and Suraiya wanted to share.
So, you go. So first, to have bilingual staff members that they can like navigate even the patients outside of the provider room. Yep.
Yeah, bilingual staff is can be very useful. And even telephone or video interpreter can be very useful for patient you're caring for. And using simple words. I know throughout the whole presentation, I think I emphasize that a lot. You know, a lot of because of the language, my language, right? A lot of word doesn't exist, so a lot of it has to do with describing. So breaking it down for the patient, and
Like with the simple words.
Even though there's an interpreter, breaking it down, making sure it's clear to the patient. Because if the interpreter said, if the interpreter said something wrong, you wouldn't know, right? Right, providers? Right? So using the simple words, making sure that your patient fully understands.
Yep. And using visual aids that help a lot more. Even to the patient that they are educated, it will help them as well to see what is going on or what we're gonna give the treatment or what the problem they are having. Like they're having something in their womb, or the patient is having some kind of like cyst. They don't know where it is, so we just draw or we show the pictures. So it's so helpful and useful.
I think also just read the nonverbal cues. I think sometimes we're so focused with our task at hand, we're typing away on an EHR, and they're really just sitting there. They're wanting to show us with nonverbal communications, and I think I've had to learn that the hard way, and just reading the room, reading how they're treating their family, and kind of picking cues up from there. And then lastly, really just celebrate the differences. It is very different. But use that to your advantage. Enter into those differences with humility. I think we have one more minute if anybody having a burning question or a word you want us to help you interpret. Yeah, I think the question is, do you train your staff in particular to become cultural navigators? And the answer is yes. Kind of naturally, they become a part of that. Yeah, I think with Suraiya and Todd, they've just shown us how this is what my community is like. And unfortunately, or fortunately, at Ethne, we have patients who speak over 40 languages, and we only have 10 languages on staff. So there are 30 more that we're still having to use phones, and I don't know the culture well enough. You can kind of make generalization, like you're from this part of the world, but ideally, if they're in person with you, they share with you some of the cultural beliefs before you enter into the room is really helpful. Do you feel like you're more of a cultural navigators as well as interpreter, or both?
I would say both. Yeah, both.
Yeah.
We are culturally sensitive in our clinic, and we have to show our providers that how this is like our culture, people, like what they think, how they want you to treat them. So yeah, so we are both like navigators and the interpret. I mean, I would say all three: navigators, interpreters, and culture.
Yeah. I would say in every conversation I have with patient, especially when it comes to like resource or like anything, inform them about their specialty appointment. I would try to culture them. They're here a little, there a little, as much as I can. Yeah.
I'll just give a quick example. Recently, it was Eid, so the end of Ramadan, and it was Eid, and this patient walked around the clinic and gave everyone candy and brought like providers candy, and in my head I'm like, is this less than $20? Can I take it? And then they're like, just eat the candy. I'm like, yes.
Just take it.
Because culturally, that's a respectful way of enjoying
And
this.
And sorry, I'm cutting you off, but if you don't take it, they will think that it's not a good thing, that they don't like us. That's why they're like not taking it.
So we ate the candy.
You have to.
But yeah, well, let's give them a round of applause, and thank you guys for spending your time with us.